Yeah.
I mean, I throw
Well,
it out
let
there.
me interject here for a moment,
Yeah.
since we're right at 2 o'clock,
Yeah.
and might as well get started with the formal presentation, even though we now have a topic to discuss at some point even further, perhaps, Artera, which is a significant breakthrough over the past few years. And but I did want to introduce Rachelle Rodriguez from Moffitt, who has been gracious enough to allow us some time with her to go over some of the inside scoop on what Moffitt can do. And I think we're basically recovering from a number of years where we didn't have a very close relationship with Moffitt. Not out of any particular standing on anybody's part, but I think we were distanced just far enough between Sarasota and Tampa that was a problem for us, but also we didn't have a history of connecting, but we've developed a recent history that I think will prove positive for everybody, in that Moffitt now this will be our third speaker from Moffitt in the past couple of years. And we wanted to develop more and more of a relationship because they're really one of the primary cancer centers in the country. And most recently have really pushed, I think, dramatically forward in the prostate cancer area. So without further ado, I'll let Rachelle take over. And I know you have a presentation, and we're going to introduce a couple of more people that are in the waiting room, and we'll quietly await to hear from you. Okay. And thank you, Rachelle.
Oh, you're welcome. So as David said, my name's Rachelle, and I'm the APP manager at Moffitt Cancer Center in our GU department. So I've been at Moffitt for about 9 years now, working in GU the entire time. APP is a term that encompasses both nurse practitioners and physician assistants, so advanced practice providers. In our GU department at Moffitt, we have 25 APPs across our department. So, like David said, Moffitt is the only NCI comprehensive cancer center that's based in the state of Florida. We are not super close to Sarasota, but as far as patients that we see, we definitely see a wide variety of patients, and we see a lot of patients from that area. Recently, within the last year, we've opened our South Shore or Ruskin location, which is a little closer for patients coming from the South as well. And we do have urologists and radiation oncologists who go to that location. So it's expanded a lot of our patient population that we see. And it's made it a little easier for patients who aren't within the immediate Tampa area.
Can you tell us, Rachelle, where that is? Because I know that is a location that some of our guys have gone to.
Is that in Sun City? Or is it
Yep. It's in Sun City Center.
Yeah.
And it's about 35 minutes or so from our main location, but because of its proximity to 75, it's a lot closer for people coming up from the South.
Right.
And you do all imaging and lab studies there as well. Also, a lot of our patients that we see with prostate cancer are seen via Zoom or virtually. If we're following PSAs, a lot of patients opt to have their PSAs done locally at like Quest. And then they see our APPs or physicians via Zoom to review those results and set up the plan. And we can do Zooms with any patients as long as they're within the state of Florida. And our APP group, those that see a lot of prostate cancer patients, are currently situated at about 75% virtual clinics. So that is a large portion of our virtual patients. So we do have options as well that don't involve traveling here. Obviously, for anything that's physically being done, a prostate biopsy, a procedure, those are all done here at the main campus. But imaging can be done a little closer at that Ruskin location. Patients can have a Zoom visit so that those results are available and they're able to review them with us. This is just a little bit about how Moffitt has grown and where our various locations are. So in the middle here, we have our main Magnolia campus. That's the one that's on the USF campus. The one that's going to be closer to you guys is down here off of 75, and that's our South Shore location. We also have a location at International Plaza, so close to the airport. And we have a McKinley campus as well as Wesley Chapel. And in January, we'll also be opening our Spiros location, much further for you guys, but that's the one that's going to have the proton center. So a lot of interest from our radiation oncology partners up there as well. We expect to have a good representation of prostate patients there. As far as Moffitt Cancer Center as a whole, so when I use that term APP and how I explained it with the nurse practitioners and the PAs, here at Moffitt, we have about 600 APPs across all our campuses. We do have more APPs than we do clinical and research faculty. Uh, in urology, that also proves true in my department. We have 14 urologic oncologists. So those are surgical urologists who are all fellowship trained. We have one general urologist. We have four medical oncologists specific to GU. And then we have 24 APPs and myself, so a total of 25. And our APPs see new patients as well as established patients. And we also have APPs who work on the general urology side that see patients that may not have a cancer diagnosis or may not have a cancer diagnosis yet. They're still undergoing that initial workup. So we do have a lot of capacity to see patients, especially in this prostate cancer realm. It's one of our largest undiagnosed populations of patients that we see. Over the last year, we've kind of redesigned our workflows for seeing new patients so that we're able to get new patients in sooner. A lot of the feedback we heard specific to our department from the community was that it was sometimes taking men anywhere from 6 to 8 weeks up to 3 months to get in, get an MRI, get a biopsy, and kind of get their workup going. Most of the times, we offer an initial appointment for patients with an elevated PSA with one of our APPs, and that's typically offered via Zoom. So again, patients aren't coming here for that. We're reviewing your records. We're going over the next steps, whether that's that you're still needing an MRI, whether that's that we need another PSA, whether you've had an MRI, you've had an elevated PSA, and now we're talking biopsy and next steps. So we're able to see you remotely, go over everything, and get your biopsy scheduled with one of our surgeons so that you're also able to kind of make the most of the time that you do spend actually coming here where we're getting things done and you're not feeling like you have wasted trips where you're coming sometimes a couple hours away and nothing happened at that visit. So a lot of our APPs have helped kind of streamline that workflow where we're able to get patients initially seen within 2 weeks and then get them to biopsy within the next week or two after. So since this is one of your focus, prostate cancer, when we're talking about prostate cancer screening guidelines, so any screening guidelines for cancer are generally going to come from the American Cancer Society recommendations. Those recommendations have a lot of the verbiage has changed over the years where there are ages where things are recommended, where PSA testing may be recommended. The biggest thing is that any prostate cancer screening guidelines should be made via an informed decision discussion with a healthcare provider. Some men may meet criteria for earlier screening based on risk factors like a family history of prostate cancer, diagnosed under the age of 65. It could be related to if they are African American, if they have multiple relatives who have been diagnosed. They're using the term average risk as well. And then the flip side of that is it's also an informed decision discussion with the healthcare provider on when that testing should stop. and when we should change the timeline or the frequency of testing. When patients do get tested and they have their PSA done, then there is a discussion about what are the next steps from that. The other big change over the years has been whether PSA testing and prostate cancer screening must include a digital rectal exam. And the answer is no. We check PSAs. That's why we're able to do this evaluation via Zoom for this initial elevated PSA discussion. A DRE may be necessary for patients when we're talking about treatment, but it's definitely not required at the beginning of that diagnosis and during that screening process. When we're looking at what does a PSA screening test mean when we're talking about early detection of prostate cancer, some of that is also going to vary based on age. There's not an easy cutoff number that says for any men, no matter their age, this is the number we're concerned about. With PSA levels, we expect them to increase with age, just normally. In the absence of prostate cancer, we expect PSA levels to increase as men age. What we're looking at is the trajectory of that PSA. Has it increased at a steady pace? Has it been checked regularly? Is it elevated and this is the first time you've had a PSA checked and you're 65 versus having some background to look starting in, say, 45 or 50-year range? So there are different numbers we're looking at based on age for when we're going to be a little more concerned or wanting additional workup on that diagnosis. These are kind of the general rule of thumbs. However, there are patients who may have a PSA that doesn't meet these numbers, but their increase has been pretty substantial, or we look at that doubling time, and that is what's more concerning. So we do continue an additional workup, which is generally after a PSA test. If there's concern, it's generally going to be an MRI for the next evaluation. When we talk about high-risk patients, those are patients who we start screening earlier, usually at 40. And that's either they have a germline mutation, they have a strong family history of prostate cancer, they have a history of prostate cancer in their family in younger populations. And so that's when we may start that screening earlier. And then as you can see, there's also a time period where we discontinue screening. That's the same thing, an informed decision process with your provider to determine if it's appropriate for you. While we use age to kind of guide some of these, that is not the be-all end-all of the discussion. Patients can be well into their 70s and be fit, active. We expect them to have a longer life expectancy. And in some of those populations, screening and even initial diagnosis is going to continue, but it may change recommendations as far as treatment. When we're thinking about that PSA level, we have an elevated PSA. Patients may be getting their PSA checked regularly by their primary care doctor. It may be elevated, and that's when you may end up with a referral to a urologist. At that point, patients could come to Moffitt as well for an elevated PSA workup. We would generally repeat that PSA level prior to proceeding to additional workup. Based on our guidelines. So the AUA is the American Urologic Association. That can typically be repeated within a few months. However, there are some situations and scenarios where we might repeat it sooner, or we might increase that time frame to when we would check it. Again, like I said, DRE or that digital rectal examination should not be used as an initial screening mechanism. And antibiotics should not be used to treat an elevated PSA in patients that don't have any symptoms.
Same thing I got. How'd it go?
Now, when we're talking about that elevated PSA workup, like I said, generally it's going to be a repeat PSA. It's going to be imaging when appropriate, which is for our population going to be an MRI for anybody that can get an MRI. From after that MRI, we may indicate the need for a biopsy. At Moffitt, we do our biopsies image guided. And that means we're using imaging either from MRI or sometimes we have patients who had a PSMA PET scan with a lesion on it. So if there's a lesion on your scan, we would use that to also do some targeted biopsies of the lesion. When we're talking about MRIs at Moffitt, one of the questions I've had is, do we have 3T MRI or do we have high field MRIs? So in the world of MRI, high field is essentially any MRI that's 3T or greater, and we do have that at Moffitt. From a biopsy perspective, the other question we often get is, do we do transperineal prostate biopsies? And the answer to that is yes. We do have some surgeons who do some truss biopsies still, or the transrectal prostate biopsies, but we have more providers who exclusively do transperineal prostate biopsies. So that's one of the other questions that we get a lot from men who have kind of researched and are deciding what to do as their next steps. When we're talking about what can be done for prostate cancer and what do we do at Moffitt for prostate cancer, we have patients who are on active surveillance, and that's typically managed by our APPs. The patients do get back in to see their surgeon or their urologist if and when it's necessary or needed. Those are a lot of the patients that I talked about earlier that we are able to see via Zoom or remotely. Those are the patients who are on active surveillance or surveillance following surgery. Surgery, which is going to be a robotic prostatectomy, may or may not include a pelvic lymph node dissection. We have a few surgeons as well who do focal therapy. Focal therapy, so when we're talking about treating prostate cancer, whole gland therapy, like removing the entire prostate, or radiation therapy are going to be treatments that target that entire prostate. When we're talking about focal therapy, that's therapy where we're talking about treating a lesion within the prostate or sometimes just one half of the prostate. We do have the capabilities to do whole gland focal therapy, although it's generally not recommended. But from a focal therapy perspective, those options that we do include HIFU or high intensity focused ultrasound, cryotherapy, we do IRE or irreversible electroporation, and we have laser ablation as well. Radiation, which is done by our radiation oncologist colleagues. We do have patients who come in after they've received a diagnosis of prostate cancer out in the community. And a lot of those patients are seen initially as a multidisciplinary new patient, meaning they're going to see a urologist and a radiation oncologist on the same day at that same visit. So they can kind of hear the entire spectrum of treatment options for their prostate cancer. It's not a competition. It's not which one of us is going to talk you into treatment. It's just to help make that decision easier because you're able to hear the whole conversation from two specialists. Hormone therapy, so that's the androgen deprivation therapy or ADT like we were talking about. At Moffitt, it's a little different than out in the community. In the community, a lot of the times you may have your urologist ordering these medications. Here at Moffitt, our medical oncologists are the ones who manage patients who are on hormone therapy. But we do have patients who are followed for that. Chemotherapy, that's also managed by our medical oncologists here. Same thing with targeted therapy and immunotherapy. One of the other treatments we sometimes get questions about is Pluvicto, which is a radiopharmaceutical, and that's administered by a nuclear medicine. Um, and we do have patients who are referred or come here for Pluvicto as well. They are generally seen by one of our medical oncologist colleagues first to ensure that they would meet criteria. We also have in clinical trials, and those are managed by our medical oncologists as well. When we're talking about non-cancer treatments and non-cancer conditions that may be managed at Moffitt. So as a cancer center, we do not have a large team of general urologists. Most of our urologists here are surgical urologists. They can manage some of these non-oncologic conditions, but now that we've continued to expand and have a strong general urology practice here as well, we do have most of those seen by Dr. Nicholson, who's our general urologist, or there's two APPs who work with her, and they both have clinics at that South Shore or the Ruskin location. So one of the big things that we see would be BPH or urinary issues. Anytime we're talking about BPH and urinating, our patients are always going to have to do their symptom score. I'm sure you guys have seen this and filled this out numerous times. Given your interest and connection to this group. So I'm sure this is nothing new to you, but we do use that. And we do see some patients with elevated PSAs that may undergo a workup that ends up being benign, but we have other things to talk about and treat with them. So we're talking about those more problematic issues like lower urinary tract symptoms or LUTs could be from BPH. When we're talking about patients who should be referred to a specialist, that's typically going to be patients who have not responded to a trial of medication for BPH. Any patients that have an abnormal prostate exam, any patients that have blood in their urine, uh, macrohematuria or blood in your urine that you can see absolutely warrants a urology referral. We also do see patients with no cancer diagnosis, just for hematuria, microhematuria, or hematuria that you may not see to the naked eye, but may be told by your primary care doctor was present on a urinalysis. Those are things that would require or should get you a referral to urology. And those are things that you can also see one of our providers here at Moffitt for. Severe urinary tract symptoms, not responding to medications. When we're talking about what do we do for these, initially we talk about lifestyle modifications, behavioral modifications. We talk about initial medical therapy, and some of this, by the time patients get to urology, have already been done. So the patients we may be seeing have likely already kind of passed through all of these steps and still have significant symptoms. And that's when there's going to be an additional workup that likely is going to include some direct visualization with a cystoscopy, some measuring of post-void residuals to see if patients are emptying their bladder, and then talking about what are the options for treatment after based upon those symptoms. I know you guys have previously heard from Dr. Parikh in interventional radiology. He sees patients with BPH or urinary symptoms for prostate artery embolization. We also have procedures that our urologist here can do. She also sees patients post therapy for prostate cancer. who may have urinary incontinence afterwards. She does do artificial urinary sphincters. So we have a lot of things that do happen in the community here. There are some things, though, that we don't offer here that are done in the community as well. So there's definitely still a place for general urologists who may manage more of those benign conditions than we do here. So at Moffitt, do you have to have a diagnosis of prostate cancer to come here? And the answer is no. We see patients who have been diagnosed with prostate cancer as well as those without a diagnosis of prostate cancer. That elevated PSA clinic that I talked about, that's typically an initial appointment via Zoom with one of our APPs. They are specific urology APPs, so it's not like equal to your generalist or your primary care doctor. They arrange for additional testing, which may include a repeat PSA at Moffitt or locally, imaging and/or biopsy. We do have some of our APPs who are also procedural, so they do biopsies, they do cystoscopies, and they assist in the OR as well. We don't only see patients at our main Magnolia campus. That's the one at USF. We have Zoom options and closer to you guys, the South Shore location. One of the things that I wanted to also bring to your attention is we do some Meet the Experts, and conveniently, our Meet the Expert session this week on Wednesday is with Dr. Rodrigo Rodriguez Pessoa. He's one of our urologic oncologists here at Moffitt. He does treat prostate cancer and bladder cancer. This one specifically on prostate cancer, though, it's via Zoom. It's from 10 to 10:30. And I sent this slide over to David as well so that he has the information to give you. You do have to RSVP if you'd like to attend. You can either call this number or email our library to get registered if you guys are interested. But it is another option where you can hear one of our urologists specific to prostate cancer talk.
Okay.
Yeah.
And then I know you guys were talking some before we started about Decipher, Artera, some of those risk stratification tools. So any of those are going to be used just to help kind of stratify risk. So when we're talking about risk, there's sometimes we may want some additional information to determine, are you someone who, we should recommend treatment for? Are you someone who is actually a great candidate for active surveillance, especially in those men who are highly concerned about side effects from treatment, whether that's surgical treatment, radiation, ADT? Is it an okay option? Is it a good option? Is it a bad option for you to consider those treatment? Those are just additional tools. The Artera is a little different because, like I said, it uses AI. So it's a multimodal model that's looking at tissue from pathology, and it's going to give us more information on your candidacy for treatment and how you may respond to that treatment. Similar to a Decipher in that it just helps to stratify risk. Are those things that we always order here at Moffitt? Not necessarily. Can we and do we? Yes. We do sometimes request Decipher on patients outside biopsies if it hasn't been done. When patients already have a diagnosis of prostate cancer, when it may change treatment, which for prostate cancer, this may happen frequently. We do also request a second opinion review on your pathology slide. So that means we request them to be sent here for a second review from our pathologists. Why would that change things, or why would that be different? So at Moffitt, of course, we have various departments, like we have the GU department where we're only seeing genitourinary malignancies. Our pathology department is set up the same way. So our pathologists are specific to GU, meaning they're not looking at a breast biopsy, a lung biopsy, and a prostate biopsy. So they're only looking at prostate, bladder, kidney, penile, testes, and those are the only diagnoses that their reading pathology slides on. Sometimes it may result in either upstaging or downstaging of a local pathology report. Not always. Sometimes our pathologists read it and come back with the same report that you had previously, but there are some times where that may change our recommendations, whether it's an upstaging or a downstaging. So we do that for any of our patients. And whether you're seen via Zoom or in person or by an APP or by one of our physicians, that doesn't change that. That's generally requested immediately upon scheduling. It just takes time because the slides have to be located, they have to be sent here, and then they get reviewed. What other questions do you guys have?
Wow, you've covered, my goodness.
So I just had a PET scan done, and how can I coordinate a question here? So with the biopsy, percentage of pattern 4 less than 5%, but I had 3 of those, less than 5%, 3 lesions. And this one, I'm wondering, how does one, other than radiation oncologist, read a PET scan? Because I'd like to sit down there in my easy boy chair, lazy boy chair, and read this and kind of like understand it more. And when I read this, I come to no conclusions, or I wish it would just speak English. There's another whole language, and
Yeah, so when we're looking at so who needs a PSMA PET scan, generally insurance, without us having to either plead our case or argue, any man diagnosed with intermediate risk prostate cancer, unfavorable intermediate risk. So that's Gleason 7 4+3, or you can be unfavorable based on the number of cores that are positive and your PSA prior to your biopsy. So any man that is an unfavorable intermediate risk prostate cancer or greater should get a PSMA PET scan, and it will be covered by insurance. The PSMA PET scan is a little different than a standard PET scan because the radiopharmaceutical they're using is specific to PSA. So when they're looking at that report, the way we see the images, we do get a similar image to what we get with an MRI, where we can see the prostate, we can see lesions, we can map based on those lesions for a biopsy. So that portion is pretty similar. The other benefit of the PSMA PET scan is because of that radiopharmaceutical, we're able to see hot spots within that. So we're able to see where there's PSA cells. So if you have a diagnosis of prostate cancer, which you have to get the PSMA PET scan, we expect your prostate to light up. So it should come back that there is disease within the prostate. That is an expected finding on a PSMA PET scan. Usually, more importantly, what we're looking for on that PET scan is there any uptake within lymph nodes? Is there any uptake within bone? Prostate cancer is a little different than when we think about normal cancers, where you're thinking they're going to spread through the lymph nodes first and then they're going to go to other organs. Prostate cancer can spread to the bone without being in your lymph nodes. It can be only in your lymph nodes. You can have a super high PSA and still only have prostate cancer within your prostate, and it can be completely localized. So the PSMA PET scan just gives us a little additional information. Usually, the clearest portion from there is going to be the bottom part, where there's usually an impression or a findings. And that's where it's usually spelled out pretty clearly. Uptake seen within the prostate. And it may say no focal uptake within lymph nodes, no focal uptake within any other areas. It may specifically mention lymph nodes. It may specifically mention bone. It may say no osseous metastasis or no evidence of osseous uptake. The other thing we can see is, does it look like it's extending out of the prostate capsule? That is generally going to be pretty clear on that report, but that's when a lot of the times when we're talking about treatment, especially for patients who are still considering surgery, that's when that DRE may be beneficial and needed, because that's when we might be feeling the tissue to see, does it feel very indurated? Does it feel like it may extend further or closer to the rectal wall? Just because that can inform some of those risks for surgery.
Can I ask you a medical question here?
Mhm.
So let's say a doctor is going to perform brachytherapy, specifically LDR.
Mhm.
Is there a procedure when using a gel such as Spacor to create a barrier between the rectum and the prostate? Is that like, you should always do it, or is it, well, no, because there's literature that says that's not really beneficial and can actually harm a patient?
We do space OR for patients getting brachytherapy. Some of it is dependent upon the location of the lesions within the prostate. So our brachytherapy is, of course, done by our radiation oncology colleagues. But for a lot of those patients, they communicate closely with our urologist. Dr. Pausang, one of our urologists here who only treats prostate cancer, he does a lot of the space ORs or the fiducials for our radiation oncologists for patients undergoing treatment.
So no detrimental, anything that might cause something else down the road from that itself?
I mean, there can be risks with any treatment, even not just brachytherapy, just radiation in general can have other risks down the road. Just like when we're talking about surgery, there can be risks related to that. Some of the more common ones we see, especially in patients who have radiation to their prostate when they're younger, just because they have a much longer time to live. We know that radiation can increase your risk of developing secondary cancers. So when we think about where your radiation is for prostate, the big ones there are going to be bladder cancer screening that may be required in the future. The other things when we think about radiation is some of the side effects from that can be more longer term side effects. So you won't have any initially, but 5 years later, 10 years later, you could develop irritation or inflammation within the bladder from that radiation and have like a radiation cystitis. Now, when we're talking about cutoffs for surgery, there are no clear cut, we would never recommend taking your prostate out at X age. Usually that's going to be more related to the overall well-being of the patient, kind of your fitness level coming in. But most of our surgeons tend to lean towards radiation for patients who are 75 years of age or older, only because we have a lot of research for many years comparing radiation to surgery for prostate cancer. And what that literature tells us looking back is that for patients with intermediate risk prostate cancer who may be eligible for radiation or surgery, they are pretty equal from an efficacy perspective. So one is not necessarily better than the other over about 10 to 15 years. We know that patients who have radiation have a higher chance of having a recurrence, but that recurrence is generally further out, say 10 or 15 years out. So for patients who may be 75, we may be less concerned about there being a higher risk of recurrence in 15 years versus someone who's, say, 50. So that's some of the times where we kind of may say one treatment is significantly better for a patient than another. But the side effects from treatment in general, between radiation and surgery, even the focal therapies, are generally patients' biggest factor in making their decision. And some of that is just having that informed discussion with them from the beginning. And that's why a lot of the times for these patients, it's nice to be able to talk to one of the surgeons and the radiation oncologist in a setting where it's not like a competition. One isn't going to be incentivized more so to get you to surgery versus radiation. So there's patients will ask like, what should I do? And in some cases, there really isn't a clear cut, this is what you absolutely should do. It's more just having all of the information and seeing what you feel comfortable with.
Yeah, that really speaks to our mission here of getting guys informed so they can make a decision.
Yeah. A lot of the times, I mean, I've seen a lot of new patients in person and via Zoom in clinic, even when we're seeing patients, when the surgeon has a clinic, generally there's a trainee, so a fellow or a resident, and there's one of our APPs in clinic as well. So we see a lot of new patients with the surgeon also. And I can't think of really any of my new patient prostate discussions where the patient hasn't left the room and said, you have told me more than everybody I've seen up to now. So I think that just speaks to a lot to what all of our providers are kind of about here at Moffitt. It's just getting you the information so that you can make a decision that you're comfortable with. And whether that decision is that you end up staying for treatment at Moffitt or you're getting your second or even third opinion, especially in prostate cancer, because you may have seen your urologist, you may have seen a radiation oncologist locally. Now you're coming to see another urologist here and another radiation oncologist, just getting you the information that helps you make the best decision for you.
Rachelle,
Mhm.
I'm a Moffitt patient. I was treated with SBRT
Mhm.
from Dr. Johnstone,
Okay.
and my urologist was Dr. Pausang. So I've been to the McKinley and the Magnolia campus,
Mhm.
and I use the MRI Linac View-Ray machine.
Mhm.
I'm hearing information that they have replaced that or are going to replace that. Do you know anything about that?
Um, I don't have much more detailed information than you do, except that yes, replacing that is what I've been told as well is happening.
Okay.
And Dr.
Any idea
Johnson is
why?
still here. Um, he will be one of our providers at the Spiros location as well.
Dr. Pausang?
Dr. Johnstone.
Oh, okay.
Yeah. Dr. Pausing is also still here.
Yes.
He will not be going to Spiros. He has
He was great.
plenty of people here.
And my next meeting with Dr. Johnstone is at the end of the month.
Yeah.
My PSA is trending in the right direction so far.
So you're still on just your surveillance post-treatment.
1 year
Yeah.
out, yes.
Congratulations. We do have
Thanks.
patients who have been treated in the community and because of either concern for recurrence, their PSA has increased. And so then they come to us for an opinion at that time point as well. And since we do focal therapy as well, we have patients who are coming specifically with questions about salvage therapy. So salvage therapy is any therapy after your initial treatment for prostate cancer, whether that's that you had your prostate removed and now you have a recurrence and you're getting salvage radiation, or whether you were initially treated with radiation and now you have a recurrence and we're talking about either salvage prostatectomy or salvage focal therapy.
Rachelle, I had heard Moffitt was getting the proton machine. Do you know what location?
Yes, that is at our Spiros location.
And do you know when that's scheduled to open?
January 26th of 2026.
Coming right up.
Yes. I went out there to see that location about 2 months ago. Walls are up, drywall's up. You can see there, they had the specific walls set up for the proton machine. Um, the Sparrows location is in Pasco County, so it's north. It is right off the Veterans Expressway. So me, myself, I come from the West Chase area. It usually in the afternoon with traffic takes me close to an hour to get home from Moffitt. Coming from the Sparrows location at 4:45, 5 o'clock, it took me like 25 minutes because of the expressway. So while it seems really far, if you're in any proximity to the expressway, that Veterans Expressway in Tampa, it's actually not nearly as far as it sounds. You're also going the opposite way of traffic, so it helps.
That is well, I'm in West. Was it on 52, 54?
It's off of 52. So when you're taking the expressway, it's actually that new Ridge Road extension exit.
Yes, yes, I know exactly where
Yeah.
that is. Okay.
Yeah. Yeah, it seems like it would be more convenient further north because of where it is and that it's not right off 75. It's not as convenient as it seems. It's not just like, oh, it's the north location. It's closer to everything north. Not necessarily the case, but there is going to be, like I said, the proton machine. So some different stuff there.
So the important factor from my point of view, and I guess all of ours, is that you're embracing proton therapy as part of the overall attack on prostate cancer.
Yes.
That's good to hear.
And it sounds like you'll be the first in the Tampa Bay area with a machine.
Yeah.
Yeah.
I think when they started planning the Spears location, it was the first in Florida. Since then, others in Florida have, but in this area, yes.
In this area. Yeah, I know others are slated for Q1,
Yeah.
February, March, April,
Yeah.
January. Wow, that's exciting.
Yeah.
Rachelle, my name is Don, and I'll try to be brief. I'm 86 years old, been on active surveillance for 13 years. And in March of this year, we did a PSMA test and found out that Elvis had left the building.
Mm-hmm.
I have lymph nodes. The cancer has spread to my pelvic lymph nodes, and that was it
Mm-hmm.
at the time. I've just been authorized to have a second PSMA to see the progress. At the time that I had the PSMA, I'd been on finasteride. My BPH is like grapefruit size, 125
Mm-hmm.
cc. So we were trying to reduce that. And my PSA was 5.2, which of course we would double to 10.4.
Yeah.
And at 86, that didn't seem bad. But just recently, in October, I had a PSA test, and that was 6.2 in about 7 months.
Mm-hmm.
So that didn't seem to be much progress. And the second PSMA, we'll see if it spread any further. With my urologist, we were considering quality of life versus extending the time of life. And of course, he suggested that with the ADT, et cetera, my testosterone level has always been 160 to 180, even at 86 years old. And I'm not taking any testosterone supplement. But of course, he said that'd be driven down to 0.
Correct.
And first it spikes, apparently, and then goes down. And so I met with an oncologist, Dr. Peterson, here on the St. Pete side of the Bay. And they kind of set out a program for me. And the first part was taking Casodex in pill form, I guess.
Mm-hmm.
By the way, the vocabulary of oncology, doesn't know anything about it. On active surveillance, I knew everything about that.
Right.
But never considered learning about when Elvis leaves the building. So they prescribed that, and then they had their own in-house pharmacy where they were going to give me 120 pills for 30 days to do. It started with an A. I don't remember the name exactly. But the first night that I got the Casodex, I took one pill. It was on a Thursday night. And Friday morning, when I was talking to them about this next 144 pills that they were going to send me, uh, I had to urinate with my large prostate size. It just comes up quickly. And so I took the cell phone into the bathroom and I'm urinating and I see blood in my urine from one Casodex pill. And so in that conversation, I'd already ordered the 140 pills, whatever it was, 4 a day for 30 days. But then I sat down and started thinking about all these side effects, and I decided I wasn't quite ready to make the decision to do the ADT protocol.
Mm-hmm.
And also, in the diagnosis in March of this year, starting in late July or early August, I had lymphedema in my left leg, swelling. Mm-hmm. And we tried to get somebody to do some massage, and the earliest appointment we could get was in November, or in August. So I haven't had any massage. And now, in the last 2 weeks, my scrotum and my penis have also started to swell. So I'm in a quandary as to what to do next. Do you have any ideas?
Yeah, so I mean, some of that, the blood in your urine could that be a side effect from Casodex? Yes. It for advanced prostate cancer, if there's cancer within the prostate, that could also cause some bleeding that you could see in your urine. So it's not clear that it would be completely related to the Casodex or not. If they were
Yeah,
talking about another medication with a pill, it could have been abiraterone.
yeah, I
Abby?
think so.
Yeah.
But I understand, but it only happened that one Friday.
Mm-hmm.
And then it got clear. I
Yeah.
stopped taking the Casodex, obviously.
Yeah.
But, and it cleared right up and never reoccurred again. So
Yeah.
I feel pretty confident that it was the pill, although we can't be 100% certain.
Right. And the swelling within the scrotum and the penis could be from the prostate, but it could also very likely be from pelvic lymph nodes because those
Yeah.
lymph nodes can cause swelling. That's going to increase the drainage of that lymphatic fluid to the lower extremities, but also scrotum. So that can cause some pretty significant scrotal swelling as well.
And it's very uncomfortable. You mentioned something earlier, pelvic lymph node dissension.
Mm-hmm.
Did I get that right?
Yeah, that's just surgical removal of the lymph nodes. So when we do a prostatectomy for patients that have unfavorable risk prostate cancer, we would typically remove lymph nodes, even if on imaging there was no disease in lymph nodes.
Okay. Paul saying he rendered the second opinion on my biopsy
Mm-hmm.
way over a decade ago.
Yeah.
I remember him well. And so I'm just, I don't know what to do with the swelling. I just, it's not very comfortable, obviously.
Yeah. Typically, when you have more progressive prostate cancer like that, to the side effects that are related to that are generally only going to improve when the prostate cancer is treated. So whether that is with ADT therapy, so would radiation of your prostate treat your prostate cancer? It would treat it within the prostate, but that's not going to do anything for the lymph nodes. So that's why they'd be looking at the hormone therapy. Did they talk to you about injections like Eligard?
Yes, that was mentioned.
And we do have some patients who respond well on hormone therapy, and then they're able to they negotiate it with their oncologist where they have responded, they have shown a significant, and they're able to do like ADT holidays, especially for men who are having a lot of symptoms on their ADT.
Yeah, my urologist said to try something like for 30 days and hope that the lymphedema would go down.
Mm-hmm. Yeah. The
So,
Eligard injections are usually something that lasts for like 3 months. So you're doing that and it has a longer lasting effect. But typically, yes, we start some Casodex first, and the Eligard or Lupron is the other name.
Yeah, I think Lubron was the one that I was expected to get on the next
Mhm.
appointment. But I just said, I didn't say no, I just said not now. I need to give it some more thought.
Yeah,
Because I'm 86 and I also have other comorbidities. So
right.
that there's a big competition going on amongst my.
Yeah.
Thank you for your suggestion.
Yep, you're welcome.
Anything, anybody else have on their mind that's probably spinning like my own is with all the information? Great job, by the way. Thank you so much, Rachelle, for this terrific presentation on Moffitt. My gosh, much more complete than I ever would have thought.
You're
That's
welcome.
That's illuminating because here we are, you know, we're fighting this battle. We needed what you just said to us over the last time. So,
Yeah, I'm very appreciative to you and to David for setting this up. He always does good work.
well, listen, first thing I'm going to do is make sure to get this out to the general population on our mailing list so more and more people can see it. But for those of you who are here today, thanks so much for doing it. And certainly to Moffitt, thanks so much for allowing such participation from us. And, you know, we will keep in touch with you.
Yes,
Thank you, Rochelle and David.
Yeah,
you're
thank
welcome. It was nice to meet you.
you guys. Talk to you all soon.
All right.
Everybody
Thank
be
you.
well.
Bye.
Wow. With this.
Yeah, technology, sometimes.
Yeah, it's really, I'm just thankful we were able to get it in because
Yeah,
we'd had some trouble with Zoom this past week.
okay.
And close it out even.
There he is.
Yeah. Should be a way to end the meeting. Yeah.
David Dumville, is that you?
It is. Hello, Don.
Hi, Dave.
Good job, everybody.
Thank you very much.